All right, good morning, everyone. A very warm welcome to the Trauma Grand Round, which this morning is going to be presented by the Emergency Department. I'm going to introduce our speaker shortly. First of all, just like to acknowledge the sponsor. So that's Graham from Smith & Nephew, who's provided breakfast for you. Just take some time to have a look at his display on your way in or out. I'm just going to introduce the concept of what we're going to talk about this morning, because this is not a typical Trauma Grand Round by a long stretch. And what we're talking about this morning is the trauma of trauma. And can we be heard online? If anyone's online, if they could just mute their microphones, that would be helpful. Thank you. Well, they muted my microphone, possibly. I don't really need a microphone. Yeah, we're going to talk about the trauma of trauma, which is a bit of an unusual topic, but I think it is pertinent. And when Sheng goes through his presentation, I think you'll realise quite how pertinent it is. Working as an emergency physician, as a trauma surgeon, as an anaesthetist, any frontline clinical staff in an environment like Royal Perth, we're exposed, I think, probably to a vastly disproportionate number of traumatic cases. And those can be cases involving loss of limb, loss of livelihood, loss of life, and sometimes in the most tragic and trying of circumstances. And we bear that burden ourselves, and how we deal with it, of course, is a uniquely personal experience. But there is somewhere, and I'm not entirely sure where, an expectation that we're not going to be affected by that, which really is as foolish a concept as jumping into a lake of water and thinking you're not going to get wet. And yet that dichotomy definitely exists. And we're going to try and unpack that a little bit across the next hour in the Trauma Grand Round this morning. And as a précis to that, some of what we talk about may potentially be triggering for you. And we will provide at the end of the Grand Round some resources, both local here within the hospital and external too, where you potentially, if you're affected by any of the work you do or the cases that you see or the things that you find confronting, if they are affecting you personally, we will provide some resources where you can seek some support. So without further ado, I'd like to introduce Dr. Sheng Chia, who is one of our advanced trainees in the emergency department, one of our registrars, who's going to talk to us this morning about the trauma of trauma.
Thank you, Phil. Can everyone hear me? Yeah, all right. So my name is Sheng. I'm one of the ED registrar currently working at the Royal Perth ED. So today I would like to draw your attention to the talk that I'm delivering today, which is the trauma of trauma, which sort of covers the psychological aspects of the trauma that we sort of face on our day-to-day life and work in our profession. So by the end of this presentation, you would have a better idea and understanding of the importance and significance of mental health within the healthcare staff. You would also discover the types of trauma. So we'll go through the different types of trauma and particularly focus on vicarious trauma itself and what it means and what it implies and the impact that it has on us. I'll briefly touch on what psychological first aid is. And we will also touch base on the project that we have been working on for the last 18 months, which is the Project Timeout. A little bit about self-care. And towards the end, I'll get Nicola Few, who is our Wellness and Wellbeing Health Support Education Officer, just to give a brief introduction on how you could promote wellness and well-being. So this talk itself, as Phil has mentioned, is just not limited to the trauma team or the emergency staff member. It should actually cover everyone who are directly or indirectly involved in the patient's care and their journey, from the frontline workers up to the PCA who is delivering the CPR, the radiographers who are pushing an intubated patient with an exsanguinating leg wound, also the allied health team that sort of are involved in the rehabilitation of the patient's care once they get discharged from the hospital back to their pre-morbid state. So why is this talk itself important, and why is mental health an important issue? So statistics has shown that 1 in 5 employees in Australia have a significant mental health problem in any year. 45% of Australians will experience a mental health condition in their lifetime. And in Western Australia alone, 1 person a day dies by suicide, and 1% of the population suffer from serious psychotic disorder. So what does that imply to us? So this is a rapid systematic review that was done amongst ED personnel in the US and Canada, which have estimated that amongst their ED personnel in the study, 1 in 5 of them met the diagnostic criteria for PTSD. It's nearly double that was observed compared to the first responder, which includes the police officers, firefighters, paramedics, and the general healthcare providers. It's also several times higher than the prevalence among the general population. And the study has also concluded that the prevalence of PTSD is higher among ED nurses compared to ED physicians. So 1 in 4 ED nurses compared to 1 in 8 ED physicians. So not being able to address the seriousness of mental health would have some damaging implications to our healthcare and economy. According to the Productivity Commission draft report from 2019, it cost the economy an approximately 12 million days of reduced productivity. 6 million working days were lost each year for untreated depression. The economy suffers approximately $10.9 billion a year, where 6.1 billion is attributed to presenteeism, 4.7 billion is attributed to absenteeism, and approximately $150 million in compensation claims. So I've mentioned earlier that 1 in 5 Australians met the diagnostic criteria for PTSD, but yet almost 2 out of 3 of them do not seek for mental health care. This includes the healthcare providers as well. This is an article that was recently released by the Royal Australian College of General Practitioners, which shows that 58% of the general practitioners said that they would not sought for mental health support when they are faced with mental health issue. So there is that constant stigma that influences the decision to seek care. It remains as a major barrier to seek for treatment as well as to accept treatment with recovery. It also impacts the help-seeking behavior of the healthcare providers that are suffering from the mental illness and negatively mediates their work environment. So the 3 types of stigma itself that I just want to let you know about is 1, you've got the self-stigma, where a person with mental illness starts to believe the negative and inaccurate stereotypes regarding people with mental illness. You've got the public stigma as well, where the reaction of the general population have towards people with mental illness. And then you have the discrimination, where it's a reaction to prejudice based on the stereotypes, negative stereotypes, which then affect the way how a person with mental illness is treated. So this is a study that was done between 4 countries, where they assessed the perceived stigma and barriers to care amongst the armed forces. So the study was done across the US, UK, Australia, and Canada. And as you can see from the bar chart itself, the top 2 stigma and barriers to care remain fairly similar across all the different 4 countries, where there's that fear that their unit leadership might treat them differently, as well as they would be seen as weak by admitting that they have mental health issues. Another study that was done amongst the combat medics also show pretty much similar results. So a majority of them felt that their unit leaders might treat them differently, or they might have less confidence in them, hence stopping them from seeking for mental health aid. The last study was done it's a survey that was done to ask journalists and media professionals on how they perceive PTSD and what is their response towards help-seeking behavior. And similarly, as you can see, a majority of them do not sort of seek for mental health aid because of the fear that they might not be trusted by their peers. They might have a lesser opportunity of given a significant responsibility as well. So as you can see from the last 3 studies, the barrier of seeking mental health and stigma remains fairly similar across all different professions and all different countries. This stigma itself can lead to the feeling of being hopeless or shameful, and it sort of negatively impacts the help-seeking behavior, as well as early detection and prevention. So now that you have gone through the prevalence and significance of mental health and the barriers of care, let's identify the potential triggers. Over the next few slides, I will go through the different types of trauma and also what the definitions of vicarious trauma means. Some of you might have heard the word vicarious trauma, but it might be new for some other people. So during the next few talks, we will just go a little bit in depth with regards to vicarious trauma. So what does one think of trauma when it comes to the healthcare system? This is what you guys experience as well? I just had to take it from Google. So there is no universal fixed definition for trauma. The Substance Abuse and Mental Health Service Administration has one of the best fitting definition, where they define trauma as an event or a series of events that is experienced by an individual that is perceived as harmful or life-threatening and has a lasting adverse effect to an individual's well-being. So what makes an event traumatic? It involves a threat, whether it's real or perceived. It is usually overwhelming, resulting in intense feelings of fear, as well as the lack of control. It then leaves the individual feeling helpless, and it changes the way a person understands the world, themselves, as well as others. So traumatic experience itself could be being exposed to death or threatened death, being exposed in a serious accident, or being involved in a natural disaster, or being sexually, physically, or verbally abused. These experiences itself could either happen directly to you or someone close to you, or you could be witnessing it happening to someone else. So working in Royal Perth Hospital itself can pose a challenge to us that, we see a large disproportionate amount of traumatic patients because we are the only state trauma center. We are also located in the heart of the city itself, where we see a large proportion of vulnerable people. So the people who have limited access to healthcare, people who are under the influence of drug and alcohol, and people with mental health disorder. So this being exposed to these people itself with their stories and their experiences does slowly in turn take a toll on our general well-being. So there are two kinds of work-related trauma exposure. You've got the direct trauma exposure, and you've got the indirect trauma exposure. So with the direct trauma exposure, it's an event that includes the exposure to an actual or threatened death, serious injury, or sexual violence. Indirect trauma refers to the trauma of the first-hand experience of repeated or extreme exposure to the details of the trauma itself. So one of the most serious negative cause of direct trauma is the diagnosis of PTSD. So PTSD itself, the criteria to diagnose PTSD is that one must experience a situation where they are exposed to an actual or threatened death, a serious injury, or sexual violence. This event itself must occur in one of the following ways. So the event itself could be experienced directly, or they could be witnessing the traumatic event in person. They would learn about the traumatic event that has been occurred to a close friend or family member, or the individual experience firsthand repeated or extreme exposure to the gruesome details of the event itself. So the four main category of symptoms of PTSD is 1, memory changes, where you might experience recurring memories of the event in the form of flashback and nightmares. 2, avoidant, so avoiding of talking about the event itself or thinking about the event. It may include avoiding certain places, activities, or people relating to this event. 3, the changes of behavior, which is common in people with PTSD, where they might get angry outbursts, being irritable, difficulty concentrating, trouble sleeping, as well as having symptoms or emotions that might be more intense than normal. And lastly, mood changes, which is the experience of feeling hopeless, thoughts of suicide, feeling of shame and guilt, or they could just have no feelings at all or being numb. So, indirect trauma is what you are exposed to on a regular basis. It is also known as vicarious trauma. So vicarious trauma itself, it's the transformation in the helper that results from empathic engagement with trauma survivors and their traumatic experience. It is essentially a mechanism where you're exposed to the traumatic events through your profession, which in turn impacts your emotional well-being and quality of life. It itself is not a sign of weakness. It's just being involved in your work. This is the cost of working with people who have experienced trauma and abuse. So vicarious trauma usually occurs in a cumulative fashion over time. Think of it as water dripping into a bucket, one drop at a time. So with vicarious trauma, there would be a change on how you perceive the world. So this change itself could be a good change or a bad change. So you may start off thinking that the world itself is a good and happy place, that everyone is basically good. But this view itself can be challenged by your ongoing daily exposure to the incidents of human cruelty. This change itself is known to be avoidable. So there are a few things that you can do or the organization can do to try and shift this negative thinking towards the positive end. The positive change that you would expect from this shift in how you perceive the world is that with the work that you have been doing, you tend to be more grateful with your own lives, finding the meaning of work in what you're doing. This change itself is thought to be a permanent change in people who are doing this kind of work. So this is the Vicarious Trauma Model Toolkit that has been taken from the Office of Victims of Crime for their training for the Vicarious Trauma Toolkit program. As you can see here, with the repeated exposure to trauma or vicarious trauma, you would have a change in the perception of how you view the world. With regards to the change, the response that you can get either a positive or negative change. We're just going to go briefly into the definitions of this negative and positive change. Some of these terminologies sort of coexist. There's no one fixed criteria where you fit into one particular terminology, and they sort of just interlink with one another. So secondary traumatic stress. It is an emotional duress that results when an individual hears about first-hand trauma experiences by another victim. It is a natural but disruptive byproduct of working with traumatized patients. And the symptoms of secondary traumatic stress itself does have quite a lot of overlap with the symptoms of PTSD. Compassion fatigue. Compassion fatigue is a condition characterized by emotional and physical exhaustion, leading to a diminished ability to empathize or feel compassionate for others. It's often described as the negative cost of caring. It is characterized by the following symptoms. So exhaustion, anger, being irritable, reduced ability to feel empathy or sympathy, decreased sense of enjoyment and satisfaction with your work, increase in absenteeism, as well as the impaired ability to make decisions and care for your patients. So another negative consequences for vicarious trauma is burnt out. So it is a state of physical, emotional, and mental exhaustion caused by a long-term involvement in emotionally demanding situations. Burnout itself is not unique to the population, to the people that is working with the traumatized population. Anyone else can suffer burnt out. Things that you feel that used to inspire passion and enthusiasm are lost. So what are the risk factors for vicarious trauma? So in here, I divide them into personal risk and professional risk. If an individual itself has had a pre-existing or prior trauma history, or if they have an existing psychological disorder, or if they have started in the field at a very young age, or if they're working in an isolated, inadequate support system, or if they had a recent loss in the last 12 months, it puts them at a higher risk of developing the negative consequences of vicarious trauma. With the professional risk factors, if an organization has the lack of quality supervision, or they have entrusted the individual with a higher caseload with higher acuity, with limited experience, or there's a lack in support system, as well as inadequate orientation and training, that also puts the individual at high risk of developing the negative consequences of vicarious trauma. So these are the general effects that you would get from the negative effects of vicarious trauma. You can divide this into personal and professional effects as well. So you would experience rapid pulse, breathing, feeling fatigue, feeling like you do not have the power, or feeling fearful. You might suffer from appetite or sleep changes, being irritable. You would also get relationship issues and breakdown, where you try to isolate from your family and friends as well as from your partner. The professional effects of vicarious traumatization includes performance, where your colleague have noticed that there is a decrease in the quality and quantity of your workload. You tend to avoid tasks, or you might get too obsessed with details and you might be working too hard. They also find that you might have a decrease in your morale, where there is a decrease in confidence or lack of interest. They would also notice that you might be exhausted or overworking when it comes to working on your daily job. You tend to also be detached or withdrawn from your co-workers with very minimal communication and also conflict with your work colleagues. So there are several key points in identifying strategies to prevent vicarious trauma from becoming severe and problematic. Like all plans, you've got your ABC. So 1, awareness. So recognizing the early signs of vicarious trauma, recognizing the negative effects, and making adjustment to prevent the trauma itself from becoming severe and problematic. B, which is balance. So having a good work-life balance. It is important to have a normal work-life balance to try and take time away from the work for rest and relaxation. And C, for connection, is to connect with other people, to try and obtain social support. This is through professional bodies. You could also get personal support as well as peer support. So you can see that vicarious trauma itself is an occupational challenge or hazard. So there is a need to emphasize on what the organization responsibility is to address this. So a vicarious trauma-informed organization recognizes these challenges and assume the responsibility for proactively addressing the impact of vicarious trauma. And this is through the policies, procedures, practices, and programs. So vicarious trauma-informed organization, they have a duty to train where workers are supposed to be taught how about the negative effects of the work that they're doing and how they can cope. So what are the impacts towards the organization should they not address the negative effects of vicarious trauma? 1, you've got a loss in productivity where there is a decrease in communication and the quality of service. There would be an increase in staff turnover, as well as poor organization health. Now that you have been made aware of the negative consequences of vicarious trauma, let's acknowledge some of the good effects of vicarious trauma. So 1 is compassion satisfaction, is where you get the pleasure and satisfaction from the work that you are doing. Vicarious transformation, it results in a deeper sense of connection with others, where you have a greater sense of appreciation in your life and a greater sense of meaning and hope. Vicarious resilience itself refers to the unique positive effects that transform the workers in response to witnessing and working with trauma survivors' resilience and recovery process. So the way you can look at this is that how it made the patient being able to bounce back from the situation that you have been involved in. This then would change your perception and then resulting into a positive sort of view of how you could see the world. It makes you more optimistic, motivated, and re-energized. It gives you an increased sense of hope and understanding, and it also gives you a profound sense of commitment and finding meaning to your work. All right, so moving on to the next subtopic, we're just gonna quickly talk about psychological first aid, what it is and what it means. So it includes the basic principle of psychological support to promote natural recovery. So this includes helping people feel safe, connected to others, and ensuring access to physical, emotional, and social support. I want to emphasize here that what psychological first aid is that it's not a debriefing. It's not obtaining details about the traumatic experience or losses. It is not about labeling or diagnosing. It is not about counseling. It is not something that only professionals can do. And it's not something that everybody who has been involved in or affected by a traumatic event would need. So the World Health Organization has developed this framework consisting of 3 action principles on how an individual or helper can assist with delivering psychological first aid. 1 is to look, so referring to the safety of the helpers itself and their surrounding, and then to identify and prioritizing who is in most need of support. 2 is to listen. So it refers to the way that the helper can communicate with people in distress, addressing their needs and concern. Listen and let them feel calm. And 3 is the most important bit, which is link, which has a practical outcome in terms of the helper giving information and helping people to attend basic needs and access the resources they need to cope with their situation. So we're just going to talk a little bit about the Project Timeout Toolkit. Jenny, do you want to just... So what we might do is we've just got a little handout of the toolkit and also the lanyard version as well.
Spares available in the lanyard, just circulate to those people that don't have, but we have more.
All right, so what you've got in hand is the timeout toolkit on a piece of paper. And on the lanyard, you have got the smaller version of the timeout toolkit, as well as if you turn to the back, you would see that it shows the available resources that you can access if you need ongoing psychological support. We have made a decision to try and make this into a lanyard so that you could put it into with the pile of lanyards that you have, so that should you feel at any point in time where you need someone to talk to try and remove or terminate that stigma or that barrier of seeking help, you've got the information right at your hands. Okay, so we're just going to talk a little bit about this timeout toolkit. So this toolkit itself has been generated over the course of 18 months. through the collaboration of the ED staff, so Dr. Amy Bossamworth, who was the previous locum consultant, as well as the ED registrar and Jenny Vance and Phil. It's also with collaboration with the clinical psychologists from the trauma team. So this toolkit itself is planned to be rolled out on the 19th of April this year. So this toolkit itself replaces the traditional hot debrief that often take place after a traumatic event. We have tried this for over the course of 3 months, and we've done a survey. And from the survey itself, we have made some adjustment and come up with this final toolkit. So the idea itself is not to purge your feelings or emotions publicly, but rather to provide a psychological safe, hence first aid environment for dialogues and questions or exploration of the case itself. It also could give an opportunity for further supports to be explored should it be required. So this toolkit itself is a semi-structured 5 minutes discussion at the end of a traumatic case with a particular focus mainly on psychological first aid. You can use this toolkit itself for any case that that has a particular significance. So one of the examples is like those big messy traumas or the sick traumas, or if there is an unexpected death, you could use it for maternal fetal disasters, or a case where someone felt that there might be unresolved issue like the so-called elephant in the room. You could also use it for young death or significant disability, or any set case for any reason, or any case that you find particularly challenging. So the goal is that to put this toolkit together with every single patient that is coming into the emergency department, but it's not a toolkit that you would do it on every patient you see, but it serves as a reminder that when you see a patient looking through their chart, that toolkit is there, which gives you a reminder that, hang on, is this one of the cases that you want to know about, or is this one of the cases that you need to talk about? So that serves as a reminder as well. So this project itself, the Time Out Project, it aims to provide a tool to act as a framework for teams to undergo a psychological safe voluntary discussion in the Royal Perth ED. It is meant to decrease stress and adverse psychological effects after a critical incident. It is also to train the ED doctors and nurses on how to use this tool, and also increase their working knowledge of how to deliver psychological first aid. This tool also help us collect information, further information on what type of incidents that the staff feel that require a debrief, or how feasible our hot debriefs are in our ED, as well as it also gives us more information on what are the equipment or system failure that we need to address and rectify. So looking at that piece of paper, we just want to highlight down the roadmap on how to run a psychological first aid timeout. So as you can see there, there's that introduction statement where it's mandatory to read the statement out loud every time. It helps sets the rule. You want to thank the whole team, acknowledge that it's a stressful case, and then explaining the rest of the statement itself to your team members. You then go through each component of the section itself, which is your T, your I, your M, and E. And last but not least, the closing statement is what I feel it's one of greater importance, where you thank your audience or your staff for their participation. And in that section as well, there is a mention about it is normal to have a wide range of emotional response of these cases. But if you have persistent, intrusive thoughts about the case and it's affecting you, that you should escalate it or speak to your supervisor or GP or whoever that you feel comfortable with. And on your lanyard, if you could see the back of the lanyard itself, we have just condensed this information into your lanyard, where should you feel that you have ongoing burning issues or unresolved issues or ongoing concerns, then you could access the resources that you have at the back here to try and help some of the issues that you've been experiencing. Self-care. So self-care itself, what it is what people do for themselves to establish and maintain health and to prevent and deal with illnesses. It's a very broad concept. It covers hygiene, nutrition, lifestyle, environmental factors, socio-economic factors, and self-medication. There are a few strategies that I just threw out here just to give you an idea on how to take care of yourself. So, you can go away from it all, physically and mentally, go on short staycations, playing video games, or find something to do outside of work that is relaxing. Or you could engage in activities that enlighten you or lift your spirit. There are some of these few self-care tips that you could do at the workplace as well. So, like taking regular breaks, being open about the difficulty experience at work. So any issues at all that you are having difficulty to talk to as well, try to be open about it and speak to someone about it. Also arrange for effective time and workload. Try to unwind outside of work with your colleagues. You could also access formal talk therapy or counseling outside of work, as well as seek the help of your supervisor for additional support. So the organization itself, there are a few hallmarks towards there are a few hallmarks on how a healthy organization works. So one is effective leadership, where there is clarity and clear alignment of the mission itself. So the organization as well should be respectful and mindful that vicarious trauma does exist. Also to promote peer support and team effectiveness. The organization as well should have ongoing sort of support and training to try and educate their staff about vicarious trauma. And we also have the staff and wellness team as well that helps devote priority and resources to sustain good practices. So I would just like to invite Nicola Frew, who is our Wellness and Wellbeing Education Officer, just to give a few pointers towards the Center of Wellbeing and Sustainable Practice.
Thanks, Sheng. I know you've been sitting for a long time, so I don't want to say too much. And there's a whole lot of places that there is so much overlap with our team and what we can offer you in so many of these different areas. It's actually been quite enlightening to see just how many places that we are speaking to already in the work that we're doing. The hospital has charged our centre with being part of the first response to trauma and distress among staff, as we recognise that distress is a normal response to an abnormal situation. And those are the kinds of things that we know you see all the time in ED. It's normal to experience distress and it's normal to feel upset about that. And we know that sometimes you just need someone with whom you can talk through your experience. And one of the things that we are really looking to do is working to reduce the stigma around asking for help in the work that we're doing. We recognise that psychological assistance is really important, but we sit probably as more of a triage service that we will direct people to psychological assistance if they need it. But just remember that we are here on site. We are also available 24/7 to support you. We have people on call all the time, every day. So we're right here in the hospital if you need help in that moment. Andrew Delmarco here, who many of you will have met, is one of our team who's assigned to ED along with Gemma Donnelly. You're very welcome to talk to either of us today about afterwards about what we can offer you. And we have our own lanyard card, which some of you will have as well, if you don't already have one. So please come and grab one of those from us. We offer support for patients and loved ones. If you have patients and loved ones in distress and you need some extra help, we're here for them. We have a daily wellbeing channel on MS Teams to encourage and inspire you in your work. We offer Bonstato wellbeing education for all staff, and Jenny and a number of your staff have already taken part, and we have more ED staff looking to book in coming months. We offer wellbeing gatherings for teams experiencing distress, so probably like a larger version of your time out. And one-to-one confidential support for every staff member experiencing distress. So you can contact us. We have a mobile number, which is on the lanyard card, so it's right at your fingertips. If you just need time out, you need a coffee, we'll take you off site. We'll have a coffee with you. First coffee is always on us. So yeah, please get in touch.
All right, thank you, Nicola, for that introduction. With that, I would like to end our presentation for today. Have you guys got any questions for anything with regards to the timeout tool or the access to wellness and well-being, or any questions at all?
Hey, Shane. Shane, can you hear me?
Yes.
It's Tom Redfern from Armadale. I was wondering, for those of us who don't have a lanyard, is there a digital copy that we could perhaps use? Something we could save on our phones in PDF, perhaps?
Sorry, Tom, can you repeat the question again?
I'm just wondering, for those of us who don't have a lanyard, whether there's a digital copy of the timeout that we could save on our phones?
Yes, so on the 18th of April, that's when our Project Timeout Toolkit is going to go live. So we would broadcast an email that provides the link to the Timeout Toolkit itself. We would also try and attempt to make a video just to give the staff an idea on how to run the Timeout Toolkit itself. But this is just more a exposure to what the Timeout Toolkit is. But I think there is the need to sort of educate the staff as well as their line managers on how to run the Timeout Toolkit. So it's like an ongoing process where you're going to educate the staff on how to run this Timeout Toolkit.
Thanks.
Jess, have you got any comments?
Can I just ask about the timeout process? You've already been running this as a pilot for a while? Oh, you haven't?
Of our staff and what kind of tool will be helpful for them, because it's really a psychological sort of first aid rather than a hot debrief as such, but it needs structure. So we're hoping we're going to start using it from the 19th of April, and then we will send surveys out again. I think the real trickiness with this is trying to keep it really short, because the departments are always really busy, and the time when we feel we don't have time to have 5 minutes time out is a time when we probably really need it. And we're hoping that this tool, part of the psychological first aid it's going to offer, it just gives people 5 minutes to reset. And it may be that some people are not talkers and they just want to walk and they actually don't want to sit with this. They just want to go and have a cup of tea and just feel time to reset. The other thing about this timeout tool is that the brief factual summary will be given by the team leader that's been taking part with the resuscitation, but the rest of the 5 minute timeout will actually be run predominantly by the nursing staff, so the senior nursing staff. So the actual team leader gets a few minutes to actually reset, because they're probably going to need to be running further resuscitations, etc., within 15-20 minutes of the actual incident that's taken place. And I'm very happy if anybody does have any sort of comments, thoughts or questions on the timeout tool, either in the sort of the near future, the next few days or weeks or months down the line. I'm very happy for people to contact me via my email, via my mobile, or just at work, because it's really, we want to make this for what people want, and if it's not going to address the need, then it may be we need something else.
And it won't be unique to the emergency department either. So.
Mr. Chairman, do you mind if I, through you, invite the real experts, the clinical psychologists who have been with us since we started? If anyone's online or in the room, would they be happy to comment, please?
Hi, can everyone hear me? This is Jess T in the Trauma Clin Psych.
We can hear you, Jane.
Oh, you can hear me? Wonderful. Thank you so much for your presentation. I just want to echo how important it is for everyone to take part in this trial if they feel comfortable. We are so passionate about being able to support our staff and to develop an evidence-based model of being able to empower our teams to look after each other and to recover after a difficult event. We think that this tool is based on the best research we have, but we're also going to be pioneers in this area, trying to develop a good evidence-based tool to assist. So just very, very grateful for everyone's participation and feedback on the tool. We want to make this accessible for our staff, useful and practical.
Thank you very much, Sheng, for that talk. It was really good. I just bring up a point I noticed about the positive transformations from vicarious trauma. And it seems that a lot of the positive transformations come from following patients up. So you were talking about how when we see the patients work through their trauma and become stronger from it, we get that. But we don't really get to experience that in the ED. All we see is the bad end of the trauma. And I was wondering if you or anyone else in the room had any thoughts about how we can maybe address that. I know sometimes we see around the hospital the posters of people who've been through trauma. I think that's one I walk past when I exit the ED all the time, about someone who survived a thoracotomy and walked out a number of weeks later a better person. But I just wonder if anyone had any sort of thoughts, or yourself had any thoughts about how we deal with that sort of lack of continuity and following up the patients that we see in the ED, because that seemed to be what, from what I was seeing, that was really helpful in transforming this vicarious trauma from a really bad experience into a positive experience as well. And no one may have an answer to that at the moment, and that's absolutely fine.
I mean, I think that's, I mean, it's an excellent question, number one, and I think it's a real challenge. And certainly in the pre-hospital space, when St John's Ambulance bring in undifferentiated patients, the one thing that improves their sort of wellness associated with the cases is hearing what the outcome is. And so feedback is you know, ubiquitously useful, I think, in that regard. And I mean, we've got mechanisms that we can follow patients up with. I mean, you can iSoft stalk your patient and see what happens to them on ICU or the trauma unit. But sometimes a formal process is a little bit harder to unpack. And when patients move to maybe a rehabilitation facility or to their own homes, we will lose connection with them. I think your question is a great one. And is there a one solution for that problem? No, but I agree with you. I think it would definitely help to improve the feelings around difficult cases if you knew the outcome of that case actually had some positivity at the end of it. Because what we see, you're right, we see the raw, acute, and often very traumatic components of the case. One thing that encourages me is to see some medical students in the audience. I went to medical school approximately 100 years ago, and with not a skerrick of grey hair at the time, and not once, I cannot recall one occasion where I was ever given any kind of education, information, or anything about how to protect myself in terms of my psychological well-being, in terms of my wellness from the work that we do. There was an unwritten, unspoken expectation that you just got on with it. And the fact that over the last years that has changed, I find that very heartening.
Most times traumas go well. What about when an individual or a team feels that they didn't do well, or in fact something went wrong? What's our process for that in the hospital?
So I think with this timeout toolkit that when we're going to roll out on the 19th, we would try and incorporate it in every single patient's chart. It gives you the option of whether you want to use it or not. So with any traumatic cases, so if any traumatic cases at all, whether it's gone through well or whether it's gone like there's an unresolved issue, or if anyone has a particular case about it, it is the duty of the staff itself that was running or included in the trauma to raise that issue up, and then they could do this sort of timeout toolkit to try and resolve that issue. So it doesn't have to be for only trauma that has gone bad, but it could be the trauma that went well as well, where they could identify maybe one or minor fault in the system that just needs to be addressed.
And there is also at the bottom of this a little checkbox that says, is a cold debrief required? So that's where, you know, this is a brief, meaningful intervention. This is a short discussion. This is ideally sub 5 minutes, but there'll be some times where something maybe did go wrong. Maybe there was a piece of equipment that failed, or, you know, there was a decision that maybe with the gift of the retrospectoscope you wouldn't have taken at the time, and some time needs to be given to unpacking that and exploring that and following whatever processes are appropriate, and a cold debrief might be the option for that.
And also want to comment with regards to that question. So that's why we've got the T part in there, the brief factual summary, because sometimes people have the perception that they actually did something that was wrong, but their perception of the facts of the event are a little bit different to how they may have actually been. So the timeout tool may actually iron out that, you know, somebody thought they did something wrong, but they actually didn't. If it is felt that something did go wrong, it's usually not a person thing. There's often a system thing behind it. And so therefore, that's the value of a cold debrief, which actually sort of needs to be done with in the appropriate sort of time, with the appropriate time. And when people have actually just had a little chance to actually sort of cool off from the actual event.
David, we'll get a microphone to you. There, just. It's just for the online participants, Dave, yeah.
Thanks, Sheng. Excellent talk. I just wanted to, I think bringing up maybe personal error or really things that people are going to attribute to just one person in that group setting, I think can be really deleterious to the mental health as well. So I think it's really important to be cognizant of that. But also, I just wanted to say that as someone that suffered from a pretty significant case of burnout last year with a lot of traumatic cases and things, just reaching out to colleagues and consultants in the emergency department in particular was absolutely amazing and a bit of a transformative experience, and allowed me to have some time to just back off and like get back to myself. So if anyone in the room is struggling or does struggle, just make sure you reach out to people that you trust in the department, and you know it'll probably be very helpful for you.
Thanks, David. And I would also encourage that, you know, staff utilised, you know, the resources such as in the wellbeing department. I think that's such a plethora of useful resources. And, you know, if you want someone just to sit down with you for 5 minutes, take you out for a coffee and just let you know that your feelings about how, you know, a case went are completely valid and completely normal, then it would be good to, you know, have that available to you.
And I think it's
You're on.
Yeah. I think it's really important for you to know as well that we're not operating, what you may know of the pastoral care department of previous is not how the Centre for Wellbeing is working now. We are very much about inclusive care for all people in the hospital. It is not about religious care for a religious few people. We can certainly still provide that care if that's needed, and we can connect people with the appropriate resources that they need. But we are really here for everyone, for staff and patients alike, just people experiencing distress who just need some extra support. And also in line with your cold debrief, if you have obviously that's a procedural thing, but if you have people who just are really struggling after an event and just need to actually talk about what actually happened and talk about how they're still feeling, and that residual sense of, you know, whatever emotions are still coming up, that's where we can actually step in and help you run a wellbeing gathering as well.
Okay, are there any further questions? We're a little bit tight for time.
Lola at the back just suggested in relation to your question that the NUMs could email your NUM with follow-up or outcome of cases. We already do that for all the paramedics. We send them within about 48 hours, we send them a list of injuries and how the patients sort of do.
That would be very helpful.
We could set something up.
Great. Okay, well, I'll close the round there. If you could please thank the speakers.